Welcome to this CME on complications that arise with warm autoimmune hemolytic anemia. I am Bruno Fattizzo, along with Irina Murakhovskaya. Here are our disclosures. Autoimmune hemolytic anemia may be considered like a multisystemic disorder with potential life-threatening complications. This may occur at the onset of the disease, so very close to the diagnosis, or during the course of the disease. Some of these complications may be related to the hemolytic process itself. Some other may be more linked to the iatrogenic effect of the immunosuppressive therapy administered to the patient. The most feared complications include infections and thrombotic complications. And there are some more rare forms, like for example acute renal failure, that may occur during very, very severe and acute hemolysis. Also, other complications like ischemic complications due to very extremely low levels of hemoglobin may be observed in a small fraction of patients that would require admission to the ICU. It has been calculated that some of these complications increase the risk of mortality in patients with autoimmune hemolytic anemia. And in the box on the right, you can see the various hazard ratios calculated for the different disease complications. For example, we see Evans syndrome, which has a hazard ratio of 8, which means that it gives you 8 times a higher risk of mortality in a patient with autoimmune hemolytic anemia and Evans syndrome. Acute renal failure 6 times, infections against a hazard ratio greater than 4, and multi-treatment, so a patient requiring several lines of treatment, also has another ratio of 4, which means that a patient receiving multiple lines of therapy would have an increased risk of complications and autoimmune hemolytic anemia-related mortality. Thrombotic events are usually not associated with mortality, possibly because we are becoming more and more aware about thrombotic complications, and prompt prophylaxis may be established. So focusing on thrombosis in warm autoimmune hemolytic anemia, there are several reports in the literature, mostly retrospective studies on large series of warm autoimmune hemolytic anemia patients, showing a prevalence of thrombosis ranging from 10 to 20% of patients. These thrombotic complications have been linked to the first part of disease course, so usually occur during the active hemolysis, very close to disease diagnosis, usually within the first 3 months from diagnosis. Thrombotic events are mainly interest the venous district and are deep venous thrombosis and pulmonary embolism, but also atypical thrombosis may occur. Some markers that may predict the occurrence of thrombosis in patients with warm autoimmune hemolytic anemia are the levels of hemoglobin, so very severe anemia, less than 6 grams per deciliter at onset, the presence of active intravascular hemolysis as shown by LDH levels increase, generally greater than 1.5 per the upper limit of normality, and history of treatments that may be related to thrombotic risk. As we heard from the section on treatment, splenectomy is particularly linked to a thrombotic risk. Also associated conditions like, for example, solid tumors, transplant, but also the positivity for antiphospholipid autoantibodies may be linked with increased risk of thrombosis in patients with autoimmune hemolytic anemia. However, as we mentioned before, it doesn't seem that thrombosis increases the risk of mortality in patients with warm autoimmune hemolytic anemia. And this is probably thanks to the consideration, to the awareness regarding the possible prophylaxis of DVT in patients with. Recently, we studied our series of patients with autoimmune hemolytic anemia to evaluate some predictors of thrombosis, and we confirmed that low hemoglobin, so less than 8 grams per deciliter, at diagnosis and active hemolysis with LDH levels greater than 1.5 per the upper limit of normal range are particularly linked with thrombosis events. So we proposed an active prophylaxis, antithrombotic prophylaxis with low molecular weight heparin in patients presenting with hemoglobin less than 8 grams per deciliter, increased LDH level greater than 1.5 per the upper limit of the normal range, and in patients with associated risk factors for thrombosis. And as we can see in these graphs, going from A to F, in the various situations, the presence of the presence of multi-treatment, particularly requirement of a second line with rituximab in box B, or the requirement of cyclophosphamide, as we can see in box B, are all factors associated with higher risk of thrombosis, which means that in patients with chronic relapsing autoimmune hemolytic anemia, we need to be even more aware of thrombotic risk and consider prophylaxis every time the patient presents with low hemoglobin levels and increased LDH. Another complication that is linked with increased mortality in autoimmune hemolytic anemia is infection. Infections may be either the trigger of autoimmune hemolytic anemia development, as we heard in the part of the pathogenesis of autoimmune hemolytic anemia, because of increased immune activation, molecular mimicry, and many possible pathogenic mechanisms. But infections may also be a complication of autoimmune hemolytic anemia. And this is important because infections are mainly iatrogenic, so linked to the burden of immunosuppressive treatment that we administer to our patient. What can we do? First, we can try to spare immunosuppression, particularly in patients with associated conditions predisposing to infections like immunodeficiencies, and also by using treatments like recombinant erythropoietin or intravenous immunoglobulin that may be used in acute phases, sparing the immunosuppressive treatment. But also we need to assess the serology for some agents, some infectious agents, like for example hepatitis B virus or hepatitis C virus, to establish a prompt and correct prophylaxis before administering immune suppression. In particular, in case of chronic hepatitis B infection, it is mandatory to establish a prophylaxis, an antiviral prophylaxis, before administering rituximab. That should be continued until 18 months after the end of rituximab course. In case of hepatitis C virus positivity, we may consider to eradicate hepatitis C virus with eradicating therapy before candidating the patient to rituximab, for example, or more toxic immunosuppressants. And then we have other infectious agents, like for example Mycobacterium tuberculosis or Pneumocystis jirovecii, then that also requires to be assessed before administering high-dose treatments, particularly for a long period, as we do in warm autoimmune hemolytic anemia, because prophylaxis may be established. And finally, of course, encapsulated bacteria should be prophylacted by the administration of vaccines in patients candidate to splenectomy. An important association is Evans syndrome. As we mentioned, Evans syndrome may be associated with increased mortality in patients with warm autoimmune hemolytic anemia. This is the clinical association of concomitant or subsequent development of other autoimmune cytopenias, including immune thrombocytopenia and occasionally autoimmune neutropenia. Evans syndrome is diagnosed in a patient presenting with at least two cytopenias, two immune-mediated cytopenias, and the diagnosis is established by the direct antiglobulin test for autoimmune hemolytic anemia, but it's much more difficult for the other two cytopenias because both immune thrombocytopenia and immune neutropenia are diagnoses of exclusion. So we need to exclude all the other possible causes virtually of neutropenia and thrombocytopenia. In fact, whilst the direct antiglobulin test has a high sensitivity and specificity, antiplatelet antibodies and anti-neutrophil autoantibodies are tests with low sensitivity and low specificity. It is even more important to assess for a secondary Ivan syndrome, so an associated condition in this context, because the association are exactly the same types we mentioned for warm autoimmune hemolytic anemia. So other autoimmune disease, primary immune deficiencies, lymphomas, and so on. But it is very important to reckon the associated condition because we may tailor treatment according to the presence of an associated condition and avoid life-threatening complications. In fact, in patients with Ivan syndrome, the risk of thrombosis and the risk of infection is about twofold that observed in warm autoimmune hemolytic anemia patients. So in patients with isolated autoimmune hemolytic anemia, the risk is lower than in Ivan syndrome. So this tells us that we need to further tailor treatment in these patients, to further administer proper prophylaxis, antithrombosis and non-infectious prophylaxis in these patients, and to avoid a huge burden of immunosuppression. As previously mentioned, reticulocytopenia, so inadequate bone marrow compensation of hemolysis, may be considered a complication of autoimmune hemolytic anemia, since about half of patients with very severe anemia with hemoglobin less than 6 grams per deciliter may display inadequate reticulocyte counts. And for these patients, the use of recombinant erythropoietin may be considered. In a recent series of patients admitted to the ICU because of autoimmune hemolytic anemia, patients mainly displayed very severe anemia, and also most of the patients had inadequate bone marrow compensation. More than 80% of patients had inadequate bone marrow compensation as displayed by inadequate reticulocytosis. And in these patients, only 22% received the recombinant erythropoietin. This is a retrospective series, but this is something, a clinical picture that we need to modify by a prompt and quick use of erythropoiesis-stimulating agents, even in this setting. Many complications may be associated with autoimmune hemolytic anemia. Particularly thrombosis is a common complication in up to 20% of cases, and thromboprophylaxis is important in high-risk situations like patients with less than 8 grams per deciliter and LDH levels greater than 1.5 per the upper limit of normal range and associated conditions.